Greetings, everyone, and welcome to the EKG case for the week of September 9th, 2013. Well, this week, we're going to spend some time talking about some pre-hospital cases. And, the past couple of weeks, I've really bombarded you with some long 20, 21-minute cases. It's always been my hope to try to maintain these videos of about 10 to 15 minutes. The problem is I just get so excited I can't contain myself to keep it only 10 or 15 minutes. But I'm going to try to do that this week. If you're becoming an EKG nerd, which is one of my hopes, then you will understand what I'm talking about. But this week we're just going to do some quick hitter pre-hospital cases and try to keep it just a little bit short. Each case is relatively brief with some really important teaching points. And also, let me take a moment to just send a shout out to all the pre-hospital care folks out there who are watching these videos. So many people, so many of you guys have emailed me and sent me some fantastic cases, and I really appreciate it. We're going to go through three cases from the Baltimore City Fire Department pre-hospital paramedic corps. They send us some great cases, and I've saved a lot of them. And intermittently, we'll take a reprieve from the ED cases and just do some pre-hospital cases. Doesn't matter, an EKG is an EKG. We can learn from them wherever the EKG is taken. So case number one, there's a 46-year-old male that presented to the emergency department. Actually, the family called 911 because he passed out. So the paramedics arrived there. They got a 12-lead EKG, and this is what they sent us, and they transported him to the ED. On arrival, he is asymptomatic. He says, I don't know why I'm here. I want to go. He sustained no injuries during this syncopal episode, and it's not a seizure, it's syncope. And take a look. This guy is really, really young. He's only 46, which is how old I am. So this is really, really young. I mean, what can happen to a 46-year-old guy? Anyway, no prior problems in the past. He is, he does live in Baltimore, so he's probably undiagnosed hypertension, and he smokes regularly, and maybe throw in a little heroin and cocaine. Who knows? But anyway, he comes in. This is the 12-lead EKG. And there's nothing notable on history or physical that gives us an answer, and that's important because when the history and physical doesn't give you an answer, nevertheless, there are certain things you've got to look for on the 12-lead where you can get an answer even though the history and physical doesn't give you an answer. And so we've done this before. We'll do it again. This is my list of things that you should always look for on the 12-lead, even when the history and physical are not giving you a clue. Now, sometimes people say, well, where's PE and other things on this list? And this is not a comprehensive list of everything you look for. But, I don't put PE on this list because really your history and physical ought to tip you off to PE, and the EKG is just a little extra. So what I'm talking about on this list are things that the EKG may tell you that your history and physical don't. So first of all, first thing you look for is ischemia. Well, to be honest, history and physical probably ought to point you in the direction of ischemia, but I'll put it in there anyway. Tachycardias, bradycardias, AV blocks. People always remember these first two things, right? Most people remember to look at the interval, especially since the computer gives that to you. When you see a short PR or long QT, those are the two intervals you pay extra attention to because this will tip you off to WPW or less common forms of pre-excitation. WPW is clearly the most common form. And then, of course, the long QT syndrome that can lead to torsade, in which you're obviously very concerned about those patients. But these two are things that people very, very frequently forget about. Hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy. Those are relatively young people, typically teenagers, kids in their 20s or so, who have exertional syncope. This is the most common cause of sudden death in young males. And so you've got to be on the lookout for this. And everyone knows about hypertrophic cardiomyopathy, but most people have not learned the EKG findings. We've covered it in a previous video cast, and we will again in the future. But just a quick summary there. The things you look for are really high voltage with deep, narrow cues in some of the leads, especially lateral leads. And almost always this is going to be in males. So if you see a relatively young male with gigantic Kuros complexes and deep, narrow cues, you've got to worry about this. Send them for a Doppler echo for confirmatory testing. And then Brugada syndrome is a hot topic that many people have heard about. And these this can be in men or women, any ethnic group. And pretty much it's been identified now in every country. And what you're going to look for is in V1 and V2, you look for an incomplete right bundle branch block pattern. And and I'm not drawing it too well, but typically, in addition to the incomplete right bundle pattern, you see ST segment elevation, there we go, and an inverted T wave, and that's going to be in V1 and in leads V2. And when you see that, you send them to an electrophysiologist for confirmatory testing, and they get an ICD, and they live. Without the ICD, they die. So these are young people with a great prognosis if you make the diagnosis, and a terrible prognosis if you miss it. And then finally, arrhythmogenic right ventricular dysplasia, which is rare, and the EKG finding is something called an epsilon wave, which is relatively rare. So it's an uncommon finding in a rare disease. I'm not going to talk about that at all this week. Hopefully we will. I've seen 1.5 cases of arrhythmogenic right ventricular dysplasia in 12 years. The half case was somebody who I strongly suspected it in because there was an epsilon wave, and then he signed out AMA. Damn, I was so angry that he signed out AMA. But anyway, what are you going to do? Let's take a look at the 12-lead EKG again, okay? There's no signs of ischemia. There's no ST elevation or depression. There's no tachy or Brady dysrhythmias or AV blocks. The intervals look pretty good, okay? So let's go back for a second. Let's cross that off, those off, okay? There's no giant QRS complexes with deep, narrow Qs. So, it's not definite, but I'm going to cross this off. What about Brugada? All right, well, you look at that 12-lead EKG, and it's not quite as obvious as what my little drawing was, but there's an incomplete right bundle with ST elevation and T-wave inversions in V1 and V2. So that was our suspicion. And this 46-year-old guy who had no family history and no prior known history went to the EP lab where they confirmed Brugada syndrome. They put an ICD in this guy. Life saved with a piece of paper and ink called an EKG, right? So good prognosis if you make the diagnosis. So that's case number 1, Brugada syndrome. Okay, case number 2 is not an uncommon case that everyone out there sees. 45-year-old woman who is lethargic. Her family called paramedics, and they arrive, and sure enough, she is somewhat lethargic. Not quite obtunded, but she's pretty out of it. She's got a history of diabetes, so the first thing the paramedics do is to check a set of vitals, and the finger stick is a vital sign itself. Her finger stick is listed as high. It's off the chart. And so the biggest concern here is DKA, right? Does she have DKA? Well, whenever you're worried about DKA, in other words, you're worried because somebody has a history of diabetes and they look sick and they have a very high finger stick. The question I ask is, what is the fastest thing that kills somebody who's in DKA? Well, it's not hypovolemia or acidosis. The fastest killer of patients with hyperglycemia who are sick, potential DKA, is actually hyperkalemia. The fastest killer in DKA is hyperkalemia, and a lot of people don't think of it that way. A lot of people think of DKA as a condition where people are total body hypokalemic, and that is true. DKA patients are total body hypo-K. But because of the severe acidosis, all of that potassium gets pushed from the cells into the bloodstream. There's a cell and there's a bloodstream, okay? And there's the potassium. That's my pathophysiology lesson for the day, okay? So when somebody's severely acidotic, what little potassium they have all gets shoved into the blood, and so they can actually have arrhythmias and death from hyperkalemia. So the first thing you do when you suspect DKA, the first thing is get a 12-lead EKG looking for hyperkalemia, and that's what they did. We asked them to get a 12-lead. 12-lead was, again, a no-brainer. This patient's got hyperkalemia, peak T waves, and so the first thing you're going to do in this scenario when you see that, get this patient started on calcium. I've seen 2 patients in DKA who had a cardiac arrest and died from hyperkalemia because people didn't really think about that. So the first thing, the fastest thing that's going to kill somebody in DKA is probably hyperkalemia. Get the 12-lead, and if necessary, give them calcium when you see those peak T waves until you get that potassium, the potassium stabilized. All right, so simple pearl, simple case, easy EKG, but a really, really important and life-saving pearl to think about. All right, case number 3, this is a no-brainer 12 lead, right? This person's got an inferior STEMI, and there's also a lateral STEMI, actually maybe anterolateral STEMI, right? Anterior leads, inferior leads. So inferior and anterolateral STEMI. Well, let me talk about the inferior STEMI for just a second. Remember that whenever somebody has an inferior STEMI, 1/3 of them will extend to the one-third will extend to the posterior part of the heart, which in this case, who cares? Because you've already diagnosed STEMI elsewhere. So if they're infarcting the posterior part of the heart, then you don't need to do anything differently. But it's also important to remember that 1/3 of patients with inferior STEMI will extend to the right ventricle. 1/3 of inferior STEMIs extend to the right ventricle, and that's important because if they have right ventricular extension, you change your management, right? You stay away from preload reducing medicines like nitrates because they will really drop their blood pressure, and that can extend the infarct. Instead, you hang a bag of IV fluids, and as long as their lungs are clear, which they probably will be, you go aggressively with IV fluids. If you knock out the right ventricle, the only source of preload is your volume status. So you need to be aggressive with IV fluids. Otherwise, there's no preload. All right. So if they're infarcting the right ventricle, you need to hang fluids and be aggressive with fluids and stay away from nitrates. So how do you know if they're infarcting the right ventricle? The easy thing to do is when somebody's got an inferior STEMI, get a set of right-sided leads. Okay. So put leads across the right side of the chest. But in some cases, you can actually diagnose a right ventricular MI even without the right-sided leads. And in this patient, you've actually got a diagnostic EKG finding that tells you, even without having to do right-sided leads, don't even bother. This person has an inferior and right ventricular MI, which means no nitrates, hang the fluids. What is the finding? There's ST depression in V2 with isoelectric segment in V1. All right. So and oftentimes you'll see isoelectric segment in V3 also. In this case, it's elevated. But the key thing is when you see that V2 is depressed, but V1 is isoelectric or elevated. So V1 is elevated or isoelectric, and V2 is depressed, and then V3 is elevated or isoelectric. So V2 just doesn't make sense because V1 and V3 are not depressed, but suddenly you've got V2 is depressed all by itself. That is highly predictive of a right ventricular MI. Okay, so simple pearl here. You don't even need the right-sided leads. So let's go to some take-home points. All right, take-home point number 1: syncope. Everyone thinks about ischemia and arrhythmias, and most people think about short PR meaning delta wave, a short PR delta wave meaning WPW. Most people look for the long QT. People have a tendency to forget about hypertrophic cardiomyopathy and Brugada. You've got to look for hypertrophic cardiomyopathy and Brugada in every EKG you get for syncope or near syncope. If you make the diagnosis, you just saved a young person's life who's got a great prognosis. If you missed a diagnosis, that young person is going to die. You don't want that hanging over you. So know about HCM and Brugada. Look for it every time. All right. Pearl number 2, hyperglycemia in a sick patient equals get an EKG right away because you've got to worry about hyperkalemia. Worry about DKA. Fastest killer in DKA is hyperkalemia. Look for the peak T waves and everything else. All right. And then pearl number 3, when somebody's got an inferior STEMI, you need to worry about possible right ventricular MI. How do you know if there's a right ventricular MI? Well, you can get right-sided leads, but on the normal 12-lead EKG, you may not need right-sided leads. If you have ST depression in V2 with either ST elevation in V1 or isoelectric ST in V1 and also isoelectric or elevated in V3. In other words, isolated ST depression in V2 in the presence of an inferior STEMI, you're done. That person has a right ventricular MI when they have isolated ST depression in V2 and not V1 or V3. All right. And in those patients, you need to stay away from nitrates, hang the fluids, and go aggressive with IV fluids. All right. So 3 quick pre-hospital cases. I hope that was helpful. And again, my thanks to the folks working out in the pre-hospital environment for everything they do and also for contributing a lot of great cases. And special thanks to the Baltimore City pre-hospital folks for these 3 cases. I hope they're helpful, and I look forward to talking to all of you next week. Bye for now.